There we are. Okay, so Ebstein's malformation, a fascinating lesion, and as Yash has told you, when we demonstrate the specimens, I'll also make the comparison with the normal tricuspid valve. That's also what I'm going to do in my PowerPoint. So this is going to set the scene for you. We should remember who Wilhelm Ebstein was. He was born in Jauer, which was then in Prussia, and he was educated in East Prussia, Breslau, which is now Rochlau, and Berlin. He returned to Breslau in the middle of the 19th century to begin his career as a physician. But he didn't stay in Breslau terribly long. He made rapid progress. He was a very smart man. And he was appointed as the professor of medicine in Göttingen, which is the major academic center in Germany, and still is. And he was appointed there in 1874. He stayed in Göttingen until he died in 1912. And the reason we now remember Wilhelm Ebstein, in fact, he also published on trench fever, but we don't remember him much for that. We remember him because of this young man. So Josef Prescher was a 19-year-old. He was admitted to the hospital in Breslau shortly after Ebstein had arrived there. So he was seen by Ebstein in the hospital. He arrived June 28th in 1864 and was complaining with the symptoms that you will all recognize as going along with what we now know as Ebstein's malformation. It was established symptoms had been present since childhood, and when Ebstein examined Joseph, he found he was blue, he found he had a big heart. When he put the stethoscope on the chest was full of murmurs, again a feature which you will recognize nowadays. Sadly, little could be done for Joseph. He was in severe heart failure. They treated him with morphine for his cough, but to little avail, and he died shortly thereafter, July 6, 1864. Now this is why we remember Joseph, because Ebstein conducted the autopsy and these exquisite drawings were prepared by Dr. Wyss. And so Ebstein, like ourselves, didn't position the heart in attitudinally appropriate fashion. So I won't be showing you the hearts like this, I will be turning them. But we can recognize what is going on. We see that in the heart of Josef Prescher, there was a small remnant of the septal leaflet of the tricuspid valve. And we're going to see that in the lesions in the hearts that we have here to show you. You also see that there is an extensive tongue of tissue here that connects the inferior leaflet and the anterosuperior leaflet. And there are these multiple abnormal muscular connections between the leaflets and the parietal wall of the right ventricle. And you can very nicely see here major thinning of the inlet part of the right ventricle that we call atrialization. But the major feature is seen here because there is an anomalous orifice of this malformed valve that points into the infundibulum of the right ventricle. The valvar orifice is rotated so that instead of pointing to the apex of the right ventricle, it points into the infundibulum. And then when you look at this second exquisite picture drawn showing you the ventricular aspect of the heart of Josef Prescher, you see to me what is the essence now of severe Ebstein's malformation. There you see the remnant of the septal leaflet. Here it is in the inlet view. But the linear and apical attachment of the conjoined anterosuperior and inferior leaflets means that the valvar orifice is a bifoliate structure that is opening into the infundibulum of the right ventricle. And to me now, that is the key for diagnosis. So if we are to relate what we learned from the heart of Joseph Pressure to what we see today, we need to find the differences in that abnormal valve compared to the normal valve, and then we need to understand the variations that you will confront in the various patients having what we call Ebstein's malformation. So if we look at the normal tricuspid valve, we established yesterday there are two junctions in the normal heart, separated by the structures that we saw were lacking in the setting of atrioventricular septal defect, and they're fundamentally different between the two ventricles. And the junction we're concerned with today, the tricuspid junction, is almost exclusively muscular and supports the leaflets of the tricuspid valve. And as we've also emphasized, within the atrioventricular junction, there is fibroadipose tissue that insulates the atrial from the ventricular myocardium. So this is a picture with which you'll all be familiar, and yesterday we emphasized the offsetting of the septal leaflet of the tricuspid valve versus the hinge of the mitral valve in the left ventricle. So this is what we are concerned with today, the right AV junction, which is discrete from the left AV junction, and between them we have the separating structures. And those separating structures are going to be very important when we discuss the conduction system, because the separating structures essentially relate to the triangle of Koch. So if I summarize what I've shown you, the right atrioventricular junction is D-shaped, the straight side is adjacent to the septum, it is discrete from the subpulmonary infundibulum with the supraventricular crest in between. I should emphasize that although oftentimes you'll see rings of fibrous tissue described, this is very rare, in most instances it's only the fibro-fatty tissue plane that produces the insulation. So here is our right AV junction, separate from the left AV junction, and the key feature, the location of the separating structures, which essentially is the triangle of Koch. So let's blow up that area, and again you see the location of the triangle of Koch with the membranous septum at its apex. Now, looking down on the right atrioventricular junction, you see the D shape. And it is the septal leaflet that is adjacent to the separating structures. Significantly, the anterosuperior leaflet is hinged from the supraventricular crest. Note that the third leaflet of the tricuspid valve is inferiorly located and is not posterior. And we can emphasize that again if we look at a short axis section. Blow up the right AV junction, and in the normal heart, we see an extensive anterosuperior leaflet, the septal leaflet with tendinous cords attaching it to the septum, and the inferior leaflet. So what we are concerned about is the inlet of the right ventricle. And we see here the coronary sinus, and we see there the right ventricular inlet, and the myocardium separates the right ventricular inlet from the left ventricular outlet. And here, between the crest of the ventricular septum and the aortic root, is the membranous part of the septum. And that is the key for the location of the conduction axis. So there is the non-coronary sinus of the aortic valve. We're now looking at it from the front. And there is the membranous septum, and you see how it's crossed by the septal leaflet of the valve, dividing it into atrioventricular and interventricular portions. If we take a histologic section across that, and I've turned it upside down this time, so there is the hinge of the tricuspid valve, what you see there is the atrioventricular component of the membranous septum. In this particular section, the interventricular component, you see very beautifully, is occupied by the branching atrioventricular bundle. And when the heart comes apart, the branching bundle, along with the left bundle branch, stays with the crest of the muscular septum. So here is a heart where I've dissected away the non-coronary sinus of the aortic valve, and you see that there is a recess that reaches almost to the crux of the heart. This is the inferoseptal recess, and it interposes between the triangle of Koch and the attachment of the mitral valve at the crux. And in front of that is the membranous septum, and that is where we find the atrioventricular conduction axis, and that will remain the situation in the setting of Ebstein's malformation. As we consider Ebstein's malformation, we also need to remember that surrounding the tricuspid valve in the normal heart is the right coronary artery. So the dominant right coronary artery will also retain its position at the atrioventricular junction, even when there is the rotational deformation that produces Ebstein's malformation. So if we summarize the normal situation, the mitral valve closes over a solitary zone of apposition. The tricuspid valve closes in trifoliate fashion. Just to emphasize again, we can now see this using multi-detector computed tomography. Schumpe's picture shows you beautifully the bifoliate closure of the mitral valve, the trifoliate closure of the tricuspid valve. So summarizing, muscular junction, 3 leaflets, septally, anterosuperiorly, and most important, inferiorly or murally. And when assessed in closed position, the valve functions as a trifoliate structure. So let's return to Ebstein's malformation and let's look at the significance of these findings. So if we are to understand the anatomy of the malformed valve, we need to take note of structure versus function. We need to remember that the valve is obviously oftentimes dysplastic, and we need to remember also that in the setting of discordant atrioventricular connections that we will discuss this afternoon, oftentimes the tricuspid valve shows the features of Ebstein's malformation. And when we talk about abnormal rhythms, that is one of the associated malformations. Wolff-Parkinson-White syndrome is particularly common in the setting of Ebstein's malformation. So I'm showing you here Ebstein's malformation with the heart in attitudinally appropriate orientation. I've marked the various leaflets, and here is the triangle of Koch. The triangle of Koch remains where it is supposed to be. Note the connecting tongue between the inferior leaflet, the anterosuperior leaflet, but there you see the valvar orifice. And it is no longer at the atrioventricular junction. Instead, it has been rotated so that it now occupies the junction between the atrialized inlet component of the right ventricle and the apical trabecular component. Echocardiographers talk about the leaflets being downwardly displaced, and that is another of the problems of not considering the situation attitudinally. Here you see the right ventricle as we would see it attitudinally, and in a study we did with Christian Schreiber, also now very sadly passed away at a very early age, we showed that rather than downward displacement, it was rotational displacement. It is a mistake to think of downward displacement. Apical displacement, yes, but preferably rotational displacement. And you see that beautifully in this particular heart, and you see in this heart the conjoined septal and inferior leaflets have rotated away from the atrioventricular junction. And that because of this rotation, it produces a bifoliate valve opening to the inlet of the right ventricle. And this looks almost exactly the same like the picture that Dr. Wyss drew of the heart of Joseph Prescher. And there you see the valvar orifice, which is a keyhole, and it is opening to the outlet of the right ventricle. That has major implications for the echocardiographer. Because if you take a straightforward four-chamber cut, as you see here, you may not see any of the leaflets of the tricuspid valve, giving you the impression that the junction is unguarded. But in fact, the leaflets are there. They have been rotated away so that the valve is at the distal extent of the inlet component of the right ventricle. It is a keyhole. I would stress, however, that that is not always present, because you don't always get that connecting tongue in the setting of Ebstein's malformation. So in this heart, for example, there is focal attachment of the anterosuperior leaflet. But that is the exception rather than the rule. In most instances, you get this connecting tongue that pushes the orifice towards the outflow, and here with hyphenated attachment, but oftentimes with linear attachment, so that the only way through is through the keyhole orifice. And on other rare occasions, that keyhole orifice can itself become blocked. And if it becomes blocked, we have an imperforate Ebstein's malformation, giving us tricuspid atresia. And then we see the distal part of the ventricle, and in this instance, being composed of the apical trabecular and the outlet components, it is fed by blood through a ventricular septal defect. So these changes in the arrangement of the anterosuperior leaflet are the key for surgical approach. And it is a spectrum of malformation, and I find it artificial to divide it, as has been suggested, into types A through D. So returning to the conduction tissue, which is our focus, the atrioventricular node remains at the apex of the triangle of Koch, and the triangle of Koch itself is normally located. Thinking of the surgeon, don't forget the right coronary artery, because it runs within the dilated atrioventricular junction and can easily be obstructed if an attempt is made to plicate the AV junction during surgical repair. Remember that the right component of a common AV valve can also show Ebstein's malformation, as you see here in the setting of an atrioventricular septal defect. Remember that the valve is typically dysplastic in the setting of Ebstein's malformation, but you can also, as you see here, have tricuspid valvular dysplasia with a normally attached valve. So dysplasia does not necessarily mean Ebstein's malformation. And remember that thus far I've shown you the findings in the setting of concordant atrioventricular connections. This afternoon we will discuss discordant atrioventricular connections, and then typically it is the left-sided morphologically tricuspid valve which shows the so-called Ebsteinoid features. And very rarely, the normal morphologically mitral valve can show Ebstein-like malformations. There is a difference between the Ebsteinoid malformation and the typical situation with concordant atrioventricular connections. In this heart from congenitally corrected transposition, you see the rotational displacement again, but without any thinning of the inlet component, which retains the comparability in thickness relative to the apical component. The associated malformations, any of these things can coexist, but when we consider abnormal rhythms, let's focus on the Wolff-Parkinson-White syndrome, although I have nothing to show you specifically regarding the morphology. So when very shortly I move over to the television camera and I demonstrate Ebstein's malformation, what I'm going to concentrate upon is the rotational displacement. And it is the septal and the inferior leaflets that are involved. And because of that rotational movement, the valvar orifice will look into the infundibulum. Major surgical variation involves the distal attachment to the anterosuperior leaflet, although, as I recall, we don't have a particular heart to show you that variation. Most of them, in fact, have focal attachment of the superior leaflet, but this afternoon we'll look at congenitally corrected transposition, and when we talk about the associated malformations, that is particularly pertinent to the abnormal rhythms. So I'll now move over and we'll demonstrate the anatomy using the television camera.